Hello, everyone. Sorry for being late. I think there might have been a little bit of confusion um, in terms of the seminar. So people might have dropped off thinking that it was the wrong seminar, but you're in the right place if you're joining us. We were running a bit behind. I'll wait for people to get onto the seminar line, and then we'll go ahead and start. Thank you guys for joining us. Apologize for the last minute sending out of the webinar. That was on me. I've been a little bit under the weather and so wasn't able to get things out on time. So I'll go ahead and start for the sake of time. So today's seminar in January, well, Happy New Year, everyone. Hopefully you had a wonderful break and the beginning of the new year is going well, at least better than hopefully mine has been going. Um, you're joining the Global Perspective on Medicine, Rehabilitation, Robotics, and Webinar Seminar. This is our January offering. We'll be talking about leveraging robot-based haptic dyads to improve community-based stroke rehabilitation. And our two speakers today are people that are dear and near and dear to my heart. My co-webinar host, Dr. Rochelle Mendonca, and Dr. Mendonca does research primarily. She's an assistant professor in programs in occupational therapy at the Department of Rehabilitation and Regenerative Medicine at Columbia University. Dr. Mendonca's research primarily revolves around technology and disability. Her funding research includes projects to develop assessments and apps that can evaluate accessibility of products and environments for people with disability. She's also funded to develop and test robotic systems for rehabilitation of individuals with stroke. Her work is focused on improving function, participation, and quality of life outcomes in life outcomes for individuals diagnosed with disabilities. Welcome, Dr. Mendonca. And our second participant and speaker today is actually my PhD student who's recently become a PhD candidate. She's very close to getting out of here. So Erica Waters is a PhD candidate in the Department of Mechanical Engineering and Applied Mechanics at the University of Pennsylvania. Her research interests includes haptics, controls, physical human robot interaction, and rehabilitation robotics. She earned a BS in mechanical engineering from the University of Tennessee and an MSc in robotics from the University of Pennsylvania. She works in my lab, the Rehabilitation Robotics Lab, and she's part of GRASP. Our lab is a part of GRASP, and she's advised by myself, and she has received an NSF Graduate Research Fellowship and recently received an NIH Ruth Kirstenstein predoctoral fellowship for the work that she'll be presenting today. So we'll go ahead and get started. They have decided their order. Please put any questions in the Q&A, and we will after they're finished speaking, we'll hold all the questions till later. You can also put questions in the chat as well, and I'll monitor those. Go ahead and I'll turn it over to the speakers.
Thank you, Dr. Johnson, and welcome everyone. We're very excited to present this work to you today. The title of the presentation today is called Leveraging Robot-Based Haptic Dyads to Improve Community-Based Stroke Rehabilitation. Erica Waters and myself will be presenting. I'll do the initial part of the presentation, and Erica will take on the second half of the presentation. The agenda or the flow of the presentation will include an introduction to stroke and rehabilitation strategies currently being used, some related work. Then we'll talk about the TheraDyad system design, current work, some future work that's in planning, as well as some conclusions around this topic. And then we're open to take question and answers from you. So I'm going to begin with an introduction and provide a brief overview of the motivation as well as the rationale for this study, as well as typical presentation for post-stroke impairment and current rehabilitation strategies that are being used with this population. So many of you have been to these webinars before, and you know that we've talked about this quite a bit in different presentations, and this is becoming a growing concern. In the rehab world, as well as the stroke world. So just to give you a little bit of statistical background around disability and stroke. So in the US currently, there are about 24.3% of the population who experience a disability or have a disability. And stroke is the third most common cause of disability in the United States. However, worldwide, this number becomes even more significant. There are about 101 million people living with stroke in the world. And stroke is unfortunately the leading cause of disability worldwide. And so, it becomes extremely urgent that we generate strategies around stroke rehabilitation, as well as try to find strategies that can improve the amount of time people get rehabilitation for, as well as the quality of rehabilitation. So just from a little bit of physiology background. So stroke typically develops when a clot develops in the brain and then gets lodged in an artery, and reduces blood flow as well as oxygen flow to the brain, leading to a stroke. And stroke is pretty devastating. It can affect pretty much all aspects of a person's functioning, including motor functioning, leading to conditions such as hemiparesis, precision, lack of precision or loss of precision, coordination difficulties, as well as muscle fatigue and endurance issues. It can also have cognitive consequences. So things like speech, memory, attention, executive functioning can be impacted. And last, it can impact all of these together, can impact functional independence and a person's ability to live independently, as well as to do the daily tasks they need to do in order to function. And these needs can end up being very complex, and also having very complex requirements in allowing a person to be able to live independently or with support, and can have pretty significant financial challenges for the individual, for their caregivers, and can place a lot of demands on the health and social welfare system and provision. When we look at the incidence of stroke worldwide, and this map kind of gives you an idea, where the darker colors are where the incidence of stroke is really high. We see that there's a large concentration or a very high incidence of stroke, specifically in sub-Saharan Africa and Southeast Asia. We also see some numbers high in the United States, but sub-Saharan Africa and Southeast Asia, where the incidence of stroke is really high, and people are younger. People who are younger are experiencing their first strokes. So the rates of strokes, as we are seeing, are really growing the fastest in low and middle income countries. Often, though, in these parts of the world are also where healthcare provision and providers are least or are lowest frequency. So when we look at practicing, this map gives you a glimpse of where practicing physical therapists specifically are located. We see that in sub-Saharan Africa and Southeast Asia, there's really a very, very low or almost absent count in some cases of practicing physical therapists. It's almost the same for occupational therapists and speech and language pathologists. And so the implication is that where the need is the most, there's the lowest concentration in those exact same areas of practicing rehab practitioners who can help facilitate people to return back to function. Even in the US, though, where we assume people receive the required amount and quality of care after a stroke, we see that only 31.2% of stroke survivors in the US receive outpatient rehabilitation services. And these are services beyond acute care, where often in outpatient rehab services, clients or patients are taught how to resume function, either through adaptive mechanisms or through regaining muscle strength, the ability to move, coordination, balance, all of those factors. There's only about 30% or approximately 30% of the population who receives this. these can have tremendous consequences, and some of these mostly are financial, where the lifetime cost of stroke in the US are estimated to be a little over $140,000. That would include inpatient care, outpatient care, and follow-up care. Um, so when looking at how physical therapists are spread out across, say in the US, and this is a map of one part of the US, rural especially, and Erica, correct me, but this is Tennessee. There is a significant shortage. So in a lot of these areas where you see the yellows, it's about a significant shortage of therapists, but what we also see is that people have to travel longer distances in order to get access to the rehab services that they need. While the U.S. costs are estimated at about 140,000, globally the impact of stroke care is estimated to tip about $1 trillion US by 2030, which is about 0.66% of the global GDP, which is a huge financial burden on economies, on quality of life of people who experience a stroke. And so need strategies in order for us to figure out how to provide care to these individuals while not burdening the economic system much more. So when we talk about rehabilitation, typically rehab happens in three different ways. The most traditional, conventional type of rehabilitation is one-on-one, where a physical therapist or an occupational therapist or a speech therapist works one-on-one with a client, or maybe one-on-two with a client sometimes, and it's really focused on that specific client and their needs and what kind of interventions will improve function for those specific clients. Here we go. However, there are some pros and cons to one-on-one rehabilitation, right? A pro is this is gold standard of care. There's a lot of evidence out there that shows that this works. It helps improve function. It allows people to resume activities at some level. Some people completely, some people to a certain extent. And it's very individual. So you can give one-on-one physical feedback, verbal feedback, haptic feedback. So it's very much geared towards being client-centered. But a con of this one-on-one rehab is that it's expensive. In the US and in many parts of the world, there are only a certain number of sessions insurance will afford these clients, as well as access varies by location. So if people are living in urban areas, there's definitely more access. However, if people are living in rural areas, the access is much more limited, and people have to travel long distances and sometimes might make the choice not to travel in order to get to get the required amount of rehabilitation. Another type of rehab is community-based rehab. Now, community-based rehab really is, like the name suggests, is offered in the community. It's not always offered in a healthcare facility. Sometimes it may be, but not always. Most of the time, it's out in the community. They are group-based. They are offered to individuals who may want to, take an exercise class, go to support groups, practice certain types of activities. But it's very much a group format, which is very different from a one-on-one rehab format. Um, and again, community-based rehab has some of its pros and cons. One is community support. So, people get an opportunity to meet other individuals who might be experiencing the same or similar challenges as themselves. It's also highly accessible because it's out in the community. You can sign up for a class, you can go to it, you can sign up for a series of classes, and it costs lower because it's being offered in a group format. So the cost of attending community-based rehab session might be much lower than what it might be to attend a one-on-one rehab session. However, there are cons because this is offered in a group format to different people who may come in with different needs and challenges. It's not necessarily always individualized. There might be pieces of it which, could be, but it really depends on who is offering the class, why it's being offered, what the purpose of it is. And so a person might not get specific feedback that relate to their, particular needs or impairments. And the last one, which we're really going to focus on much more today, is robot-based rehab. So this is something that is growing worldwide in terms of a strategy to allow people to get rehabilitation longer, both for the upper as well as the lower extremity. There's several situations in which there's integration of games, there's integration of different kinds of movements while doing robot-based rehabilitation to build up strength, to improve range of motion, potentially for some form of cognitive rehabilitation, but really to address those issues that a client might experience after a stroke. Robot-based rehabilitation is growing in that area as a strategy that works, and that could potentially not only increase the amount of time a person gets therapy, but also the quality of care. Again, pros and cons. It might be more cost effective because it might allow one therapist to work with multiple clients at the same time. There's a lot of literature out there which shows that it's comparable or a great adjunct to standard of care rehabilitation, especially in areas where there aren't enough therapists. This really is growing as a strategy to be able to provide therapy to clients. However, the cons is often it is one-on-one. So one client's working on a robot by themselves. So there's very reduced social interaction. And often these robots are set up where there is a set path for performance. So if people need to adapt to still accomplish the same task, robots don't always necessarily accommodate that. And so might be a limitation there. And so this brings us to what the presentation today is going to talk about, which is proposing a new approach of combining community-based rehabilitation with some of the individualized and haptic and verbal feedback that's possible with robot-based rehab. So really integrating these three concepts into picking out what's most possible and beneficial for improving function in clients specifically with stroke, and to see if such a new strategy works. And so here's just an example of two people working together on a system to meet a goal or accomplish a task, or sometimes compete with each other. But it allows you to work with somebody else, providing that social interaction while still working on improving function, while being cost affordable, cost effective, and accessible to a lot of clients. And so I'm going to turn it over to Erica now, who will start talking about some of the related work and some of the strategies that she's developed as part of a PhD program. Erica?
All right, so I will go ahead and talk about the related work now. So this is all based on a literature review that I did on robot-based haptic dyads, which I'll be defining here in a second. But I did want to point out that this was all published last year in IEEE Transactions on Haptics. So if you're interested, please check that paper out there. So just to start talking about the literature review, like I said, it was about robot-based haptic dyads. So this I defined as at least two humans collaborating to complete a task by exchanging forces through interaction with robotic interfaces. And so after this big literature review, I found 38 total articles. And I just want to summarize some of the main results and themes that we found in that literature review. So to start off, we found some implications for motor learning. So we found that training in this dyad, so having a haptic connection to a partner while you're learning to do a task, may actually improve motor learning overall. So specifically, we found that dyadic training results in either greater or the same learning as solo. And in those cases where we found that it was performing the same, we think that that may have been an effect, a ceiling effect, where these studies were really only investigating healthy young adults. So for some more simple tasks, we really don't expect that they have as much to learn. So if we were to use different populations or more complex tasks, we may see a bigger stratification between the dyadic group and the solo groups. Another main takeaway that we had was that novices actually learn best when they're paired with another novice. So this was an interesting result because we might expect that pairing someone who is new or novice to a task with an expert on the task would cause them to, really learn a lot more from this expert, but we actually found the reverse. So the novices who were paired with experts actually slacked on the tasks, so they were not exerting enough effort or learning the task. And they may have also seen a reduction in their motor variability. So the expert has their kind of set way of performing the task and accomplishing this goal, but the novice never gets a chance to learn the task if they're immediately paired with that expert. Another main takeaway we had was that haptic guidance is just not as effective as having this reactive human partner. So when I'm talking about haptic guidance here, I'm really referring to more traditional rehab robotics where the robot is kind of guiding you along a set trajectory or a set path. And what we found was that this haptic guidance reduced motor learning when compared to having the dyadic connection to a human partner. However, if we are able to model that human-like robot partner and make them kind of reactive as with a human, we actually found similar learning as in the dyad. So thinking about these implications for motor learning, it may be promising to use an approach like this for rehabilitation. So looking at what the implications for rehabilitation might look like, the first implication is concerning hardware. So we want to make sure that we're studying rehab devices when we're thinking about doing these kind of haptic dyad studies, because not all hardware is going to be accessible to every population. So for example, in the literature review, we found that a lot of people were using grounded force feedback devices. These are kind of like little haptic styluses, and they require a lot of fine motor skills to actually move these devices. So that might not be accessible for someone who's in the early stages of stroke recovery. We also found that the population is really important. So as I mentioned before, only healthy young adults were studied in these 38 articles that I found. And so not only do we need to include individuals who have impairments, whether those are motor impairments or cognitive impairments, but we also need to include some healthy older adults because we know that a lot of acquired disabilities, especially stroke, tend to affect people later in life. In addition, we also need to think about social facilitation. So a lot of these studies are highly controlled, so they're really limiting the interaction between participants to those forces that they're exchanging through this haptic interaction. But we want to make sure that we're actually leveraging social interaction and getting the most out of that. And then finally, we need to think about gamification. So we want to make tasks as engaging and gamified as possible so that people want to continue to do this therapy and they want to engage with the robot. So now that we've kind of talked about what other people have done and some of the implications that have been found, I want to talk about the TheraDyad system. So this is the robotic system that we've developed here in the Rehab Robotics Lab in order to study these robot-based haptic dyads. So starting out with the full system design, it's primarily made up of two TheraDrive robots. If you've attended seminars like this in the past, you may have heard my advisor, Dr. Johnson, talking about the TheraDrive robot. It's a 1 degree of freedom, affordable rehabilitation robot, and I'll talk a little bit more about it here in a second. These are connected to a single microcontroller. We use a TNC 3.6. They also each have a dedicated monitor for showing the therapy games. And then we have a privacy screen, which we can put to limit interaction to just the forces, or we can remove it so that they can talk to each other and interact. Looking now at the TheraDrive design itself, this is a slightly more updated design. So we have at the base a quasi-direct drive actuator. This actuator has a low gear ratio and a high torque density. And it also has some embedded low-level controllers. So specifically, we have an embedded low-level controller on current that we use. This is connected to a torque limiter. This is just a mechanical clutch so that if a maximum torque is exceeded, it's going to decouple the motion of the motor from the actual robot itself in order to prevent any injury. We then have a crank arm, which is connected to our force sensing handle, where our patient is actually going to hold on to the handle. So thinking now about, we have the hardware for this device and our overall goal is to have this interactive robot-based rehab. So how do we actually achieve this within the controller? And so the answer is we need this bidirectional haptic feedback, right? So as I move one device, I want you to feel it on the other device. And how do we actually go about achieving that? Well, we are going to be creating a virtual spring damper link between the two robots. So to actually talk about how we do that within the controller, we are going to start with that low level current controller. So in this case, it's a proportional integral controller on current. And We are going to then build out with the physical dynamics of the robot itself. So you can see tau sub h there is representing the torque applied by the human. They apply some disturbance torque, and we're able to set the current with that low-level controller. And now, so we actually want to build on top of this. So we're going to use a cascade control design and build on top of this with an outer loop, which is going to be a proportional derivative controller. This proportional derivative controller is going to simulate our spring damper. So we have some desired position that we can apply. That's going to go through our proportional derivative controller that's sitting on top of our current controller. It's going to be able to command that position in this kind of spring damper-like way. Now, to make this bidirectional haptic feedback, we simply want to replace that desired position with the position of the opposite device and vice versa. So just to simplify this and walk you through it a bit clearer, we are going to kind of ignore that inner loop for a moment and just think about the proportional derivative outer control loop. So to walk you through this, we start by, our person on device A is going to apply some torque to the robot, which is going to output some change in position on that robot. Our person on device B will apply some torque to their robot, which will output a change in position on device B. And this change in position from device A is going to act as the set point for device B, and our change in position on device B will act as the set point for device A. So just to kind of show you what this actually looks like in practice, as we move one robot, the other robot moves. You can think of this as a spring connecting the two robots together. As we move one, the other moves with it. And this works in a bidirectional way. So now that we have kind of our hardware and our controller for the device, I want to talk about our current work where we're investigating motor learning in a robot-based haptic dyad. And I do want to point out again that some of this work has been published in BioRob last year. So starting out with our rationale here, so from that literature review, I found that, if we have a person working with a robot to learn some task, we expect that their performance is going to increase over time. This increase in performance over time is what we'll call motor learning. If we allow that person to have a haptic connection via that robot to a partner who's also a novice at the task, we actually find that that causes an increase in motor learning. So we see a greater improvement in performance over time. However, if that partner is an expert at the task, we actually see a reduction in motor learning. And that might be due to a slacking effect, or it could be due to a reduction in motor variability. Thinking now about somebody who has had a stroke or has some other impairment, we might ask if we were to pair this person with a healthy novice to the task, would we expect that to cause an increase in their performance? Or instead, would we expect for that novice to act as the expert and cause a reduction in effort or in motor variability for our individual with an impairment? So to start to answer this question, I completed a case study. So for this case study, we have two individuals working with our TheraDyad robots. They're completing this really simple tracking task. As they go inside of the target, they turn green. When they are outside of it, it turns red. And they have this controller working between their two robots the entire time. I do also want to point out that this this task does have a little bit of a cognitive component. So they're moving in the horizontal plane, but the target itself is moving vertically. So this does take a little bit to learn to do this task. So looking now at our procedure, we start out with a clinical assessment. This clinical assessment includes motor assessment with the box and blocks test, as well as a cognitive assessment with the color trails 1 and 2. We then have all of the participants do 4 baseline trials, which they all do in a solo, no haptic feedback condition. Next, they do some usability surveys. These include the self-assessment mannequin, the system usability scale, and the NASA task load index. They then do 30 training trials, which they either complete in a solo, no haptic feedback condition, or they complete in the dyad with haptic feedback from the partner. Next, they do their usability surveys again. And finally, we end with 4 assessment trials, which everyone does in that solo, no haptic feedback condition. Looking at our participants, we had 9 participants. So 3 were stroke survivors and 6 were healthy older adults. Our conditions here were dyad even, which indicated a healthy participant paired with another healthy participant. Dyad uneven, which indicated a post-stroke participant with a healthy participant, and solo, where they had no haptic feedback in the training condition. Looking here, this graph is showing box and blocks test results plotted against Color Trails 2 test results. So we're trying to get these 4 different quadrants of cognitive and motor impairments. So you can see that in our low cognitive, low motor impairment quadrant is where all of our healthy individuals fell. This is to be expected. And then our stroke survivors fell within these moderate motor impairment and in some cases moderate cognitive impairment quadrants. So looking now at our actual performance results, this graph here is showing robot position over time. So our dotted line in black is representing the target trajectory. This is what we wanted the person to follow. In the blue, you can see their very first trial. So you can see that they haven't quite learned the mapping yet, and they're struggling to complete the task. In the red, you can see their last trial. So here you can see that while they haven't gotten perfect at the task, they are doing a much better job of following the target. So to try and quantify this performance, we are looking at an error metric. Specifically, we're using root mean square error, or RMSE. And what we found was that baseline RMSE was significantly worse for our stroke survivors than for our healthy older adults. This is an expected result, as the stroke survivors do have motor impairments. What's interesting is at assessment, we actually found no significant differences between our stroke survivor group and our healthy older adult. So this does indicate that our stroke survivors were able to learn at the task. So again, to quantify this learning, we're looking at a change in performance. So we're using this delta metric, which is just the difference in RMSE at baseline and at assessment. And here are our results overall. So I want to point out that all of our participants had positive delta, indicating that they learned, except for the healthy older adults who were paired with stroke survivors. We also saw that our stroke survivors had significantly greater motor learning than our healthy older adults, which might make sense. So to really investigate why we saw these differences in motor learning, I performed some linear regressions. So here along the y-axis, I'm going to be plotting learning as that delta score. A higher score indicates more learning, a lower score indicates less learning. And I'm plotting this against a couple of different values, but I'm going to start with Color Trails 1. This is again a cognitive task. So a lower score indicates worse cognition, a higher score indicates better cognition. And here you can see our result overall. So our individuals who had lower cognition had the most learning. Our individuals with the highest cognitive scores had the least learning. And this had an R-squared of around 0.6. So I repeated this analysis for Color Trails 2, and I found a very similar relationship. Looking now at box and blocks test, this is again a score of motor impairment. I see a very similar relationship. Our individuals with more motor impairment had more to learn than our individuals with less motor impairment. So now, thinking about cognitive impairment and motor impairment, we might think, well, maybe that's just a stand-in for how they perform initially at the task, right? So do our individuals who perform worse at baseline have more to learn than our individuals who perform better at baseline? And we did find a result to support this. So when we plot baseline RMSE against learning, we see that our individuals who were better at baseline did learn less than our individuals who were worse at baseline. So just to investigate one more metric, we now wanted to look at relative partner RMSE. So here, a more negative value indicates that your partner is worse at the task, or they're less skilled than you are. And a more positive value indicates that your partner is more skilled than you are. So these are our stroke survivors who were paired with our healthy older adults. And what we actually found was really interesting, because relative partner performance was the best predictor of motor learning. So even compared to performance at baseline or our stand-ins for cognitive and motor impairment, this was the best predictor. So just to summarize our results, stroke survivor participants were able to learn in the dyad, indicating that they do not slack when paired with healthy older adults. Our healthy older adults paired with our stroke survivors were the only group who did not learn, and relative RMSE had the highest correlation with motor learning, indicating that relative partner skill level does affect learning. And finally, overall usability scores were high, indicating that the TheraDyad is a usable system. Looking now at our full study, this is what we're proposing to do. We plan to recruit 54 participants with various inclusion and exclusion criteria, including 24 stroke survivors and 30 healthy older adults. And we plan to have them complete 3 different sessions. So starting with session 1, we're going to have them complete several motor assessments, cognitive assessments, and even some sensory assessments. Then in session 2, we're going to have them complete the same task as we used in the case study, using a similar training regime of a baseline, training, and assessment. And then we're actually adding in a retention task that's going to happen a week later. Looking now at the usability surveys, we will also use those same usability surveys that we saw in the case study. And we're also going to add in a qualitative interview, which will happen on our last day. So looking now at some of the preliminary data that we've been able to gather. So we have recruited 23 healthy older adults so far. Conditions here, we had 9 people in a solo condition and 14 in a dyad even condition. For analysis purposes, I am splitting that dyad even condition into 2 groups. We have the less skilled, who is the partner with higher baseline RMSE, and then the more skilled, who's the partner in each dyad who had lower baseline RMSE. And again, looking at our quadrants, comparing box and blocks to color trails 2, we see that most of our participants fell in this low cognitive impairment, low motor impairment quadrant. But what's interesting is that even for a supposedly purely healthy cohort, we did find some individuals presented with some moderate motor impairment or some moderate cognitive impairment, which I think highlights the importance of recruiting healthy older adults in addition to people who have been documented to have some level of impairment. So looking now at how some of these different performance metrics kind of evolve across these 46 trials, I'm going to start by looking at our error metric, which is RMSE. So a higher value here is going to indicate more error, and a lower value will indicate less error. So here you can see the results for our less skilled partner, who is in red, our more skilled partner, who is in green, and our solo group, who's going to be in blue. Starting at baseline, we're going to expect to see an initially quite high error as they haven't learned the mapping for the task yet. That's going to have a sharp decline as they do learn what the task requires. During training, we're going to expect to see sort of a leveling off, slowly reducing error overall. At assessment, we'll expect to see the lowest error overall. And then finally, at retention, we might expect to see a small jump in error and then a return to that assessment performance. Thinking now about a measure of movement efficiency, normalized distance. Here, a value of 1 indicates that they moved exactly as much as the task requires. A value greater than 1 indicates that they actually moved too much. And a value less than 1 indicates they didn't move enough. And I do just want to point out in this graph that our more skilled group has a really high normalized distance during their training trial. So this is when they had that dyadic connection to a partner. We also wanted to look at effort. So here we used mean absolute power. A higher value indicates more effort, a lower value indicates less effort. And I do, again, want to point out that both our less skilled and our more skilled partners had really high mean absolute power during the training trials. This is probably just a result of those interaction forces that we have from the haptic connection. So as you can see, we start to see some different patterns begin to emerge when we look at this at these different metrics plotted out over the trials. So to get a better idea of what's actually going on here, we did some statistical analysis looking at some two-way ANOVAs analyzed over trial and status. RMSE had a significant effect of trial as well as an interaction effect. We saw the same result for normalized distance. And then for mean absolute power, we actually showed a significant effect of status, trial, and an interaction effect. For our post hoc test, we're using Tukey honestly significant difference. So now to actually look at these results, starting with RMSE, we found that the less skilled partner has lower RMSE at training and assessment compared to their baseline. The more skilled partner has lower RMSE at assessment and retention compared to their baseline, and we found no significant differences for the solo group. Looking now at normalized distance, as we noted with that plot earlier, the more skilled partner has higher normalized distance at training and assessment compared to their baseline. And we saw no significant differences for the other groups. Looking now at mean absolute power, we found that the less and more skilled partners have higher mean absolute power at training compared to all other time points, which again is probably an effect of those interaction forces. And we saw no significant differences for the solo group. Looking to compare the groups now, we saw that the less and more skilled partners have higher mean absolute power at training compared to solo. Again, that's probably just a result of those interaction forces. But the interesting result here is that the more skilled partner has higher mean absolute power at training compared to the less skilled partner. So now I just want to go through these results and kind of summarize them. So training in a dyad may increase learning for older adults compared to solo training. And we see this in the fact that the less skilled partner improves performance in the dyadic training trials and maintains that improvement in the assessment trials. However, they don't maintain it in the retention trial. And the more skilled partner significantly improves performance at assessment, and they actually maintain that improvement in the retention trials. The solo group, however, showed no significant differences between their baseline and any other trials. We also saw that the more skilled partner may lead through exaggerated movement and high power. So our more skilled partner had an increased normalized distance from baseline to training, and they maintained that difference at assessment. Likewise, the more skilled partner had significantly higher power than the solo or the less skilled partner during training. We also think that inclusion of stroke survivors may be necessary to replicate the linear regression results that we saw in our case study. So we weren't able to replicate this analysis. So this might indicate that we need that higher spread across levels of impairment in order to see those same patterns start to emerge. So just to summarize this section, in the case study, we show that stroke survivors can learn in a haptic dyad. We also show that relative partner skill level influences motor learning. In the older adult study, we showed that older adults learn more in a dyad than in a solo condition. And we also showed that relative partner skill level influences effort. However, we weren't able to show that it necessarily influences learning. So this all leads me to this question of, can we optimize the relative partner skill level in order to improve motor learning? And this leads into our future work. So here we're looking to potentially develop an adaptive dyad controller that's going to enable caregivers to support multiplayer rehab games. So our rationale here is based on this idea. If we think back to the early days of rehab robots, a lot of them were using passive haptic guidance, where the robot fully guides a patient along a desired path. But we quickly found that this led to slacking and just a reduction in effort from the patient. They needed to be more active in their rehab. So people introduced the assist as needed approach, where we want to only assist the patient as much as they need in order to accomplish their task. So what I would like to propose is that we take a lesson from that's needed and we actually apply it to these robot-based haptic dyads. So I'm asking, can we combine robot-based haptic dyads with assist as needed techniques in order to create an interaction as needed controller that's going to adapt to relative skill level and or effort between our different partners? So there have been some attempts towards similar ideas. So Galafaro et al. Introduced a motor skill learning algorithm where they modulate the haptic connection between a novice and an expert. And they did find that this increased the learning of the novice in the novice expert dyad, but this algorithm was highly task specific. So it's unclear how it would translate to other situations or tasks. We also found have an unpublished report. So this is from Nakaro et al., where they actually created an asymmetrical connection. So springs of different stiffnesses connecting the two partners. And they found that they were able to increase the less skilled partner's performance without increasing the more skilled partner's effort. However, this was only looking at instantaneous performance, so they weren't actually looking at motor learning longitudinally. And also, this asymmetrical connection was set a priori, so they weren't actually adapting to the specific dyad, they were instead setting it beforehand. So how might we go about modifying that controller that I introduced a few sections ago? Well, the first way that we could modify this is by actually adapting the gains, and we could use an adaptive gain algorithm. So for this adaptive gain algorithm, we could dynamically adjust our gains in order to kind of regulate the relative effort between the two partners so that we create that asymmetrical connection like we saw in the Nakaro report, except this time we're trying to be dynamic and adaptive. Another option for modifying this controller is to actually change the set point. So with this adaptive set point, we can actually change the perceived position of the partner. And this way we can dynamically adjust their partner's position in order to virtually improve them. So we can kind of trick you into thinking that your partner is better at the task than they actually are in order to help you learn. And so overall, this dyadic controller might be able to potentially balance these different levels of skill, especially between, say, a stroke survivor and their caregiver. And we would want to test this in a user study in the future. So just to summarize, we propose that an interaction as needed controller could optimize motor learning with a haptic connection to a partner. An adaptive gain algorithm could create an asymmetrical connection in order to balance effort. And an adaptive set point could virtually improve partner performance and make them appear more skilled. And finally, this interaction as needed controller can be assessed with a user study with post-stroke participants and their caregivers. So now I just want to quickly conclude. So in conclusion, overall, we saw that both community-based rehabilitation and rehabilitation robotics can improve affordability and accessibility of post-stroke rehabilitation. We also saw that training with a partner via this haptic connection can improve motor learning. We found that differences in relative skill levels between partners can influence learning. And we also found that the robotic controller can be modified with assisted techniques in order to create an interaction as needed connection that's going to optimize for motor learning. And then finally, I just want to remind you that our overall goal here is this interactive rehab robotic setting. So the benefits here are going to be, this benefit of haptic feedback from a partner, the community engagement of being able to socially interact with a partner, and finally, the affordability and accessibility that comes from having these affordable rehab robots. And I will end there and leave time for questions.
Thank you. Thank you, Dr. Mendonca. Thank you, Erica, for that great presentation. There is a question right now in the chat, so we'll go ahead and ask. It comes from Ebenezer Adams. He's asking, how do we access your full study? And did the study involve only healthy individuals? And if yes, what was the reason? There's several questions. And are there plans to transfer the technology to a low research setting, especially in LMIC?
Okay, so I can start to answer some of those questions. So the study is available. I believe it should be available through the NIH if you wanted to access like the F31. However, we have published one paper already on this. So that was published at BioRob last year. And so that paper does include both healthy individuals and post-stroke individuals. In terms of the results, kind of those healthy older adults results that I presented later, so far it is just the healthy. We have collected some data from post-stroke participants, but just not enough to present. And we do plan to recruit 24 total post-stroke participants in order to include in this study. And then for the adaptive controller, we'll also plan to recruit some post-stroke participants in order to test that controller. So we do definitely plan to translate these research. In terms of actually applying this in like a lower middle income country, you would have to talk to Dr. Johnson. So I think that will maybe come post my graduation. But I think that it could definitely be translated. And I know the TheraDyad has actually already been deployed in a lot of different countries, so including like Botswana, Jamaica, and Mexico. So I think it could very easily be translated.
I could jump in and say yes. I mean, the whole plan is we have a cooperation and a grant with NIH with our R42 to look at commercialization of the TheraDrive system, and this idea of TheraDyad is a part of kind of some things that we've thought about applying to that to those collaborations. So I think it would definitely be something that we've thought about in how to take what we're learning and what Erica's PhD is kind of exposing for us in the potential of this new strategy and applying that to anything that we're doing in low and middle income countries. Any other questions? So one of the question that came up, Erica, is your initial results with stroke, and then you talked a little bit about what you're seeing already with older adults. Do you have any sense that once you get to your numbers, whether you will see similar responses and relationships between the older and the stroke survivors? And then if you don't, what are some of your plans?
Yeah, so I think we do start to see some of the patterns that we saw with the stroke survivors in the case study. We do see some of those with the healthy older adults. I really just think that the impairments that they have are not announced enough. So If we take one healthy older adult and we pair them with another one, I don't think that there's a big enough difference in their skill level to start to see that linear regression result that we showed from the case study. So I do think that when we include stroke survivors in that analysis, we're going to start to see more of that spread of data that might look like a linear relationship. It might look different. I think I'll just have to actually have the data before me, but I think we need to have that spread in terms of skill levels to start to see relationships between relative partner performance. In terms of, what was the other part of the question? I'm sorry.
If you don't see the results that you're hoping for, what would be some of the next steps?
Yeah, I mean, if we don't see the results that we're hoping for, I mean, the next step is to analyze the data and see what we do have. So I think that there are interesting takeaways. You know, I was presenting really only, performance metrics and some learning metrics for the healthy older adults. But even with that data, I still want to dig a little bit deeper into like the relative effort levels that we're seeing and see if we can better understand, is there something about working with a partner? What is it about that is allowing people to learn? So another aspect of this study that I didn't actually present today is that we are trying to do some modeling work. So we're trying to model how people interact in the dyad. And the goal of this is to better understand what is it about having a reactive partner that actually helps people to learn. Is there a certain way that people respond? Do they exaggerate their movements, which I think is what our healthy older adult data suggests, that people kind of exaggerate movements and apply really high powers to kind of lead their less skilled partner through the task. And is there, as a future direction, could we actually modify our robotic algorithms to do a better job? So maybe they exaggerate their movements more so and are a little bit more reactive to the human.
I'm going to ask Dr. Mendonca a question. In terms of from a practical standpoint, in mapping this idea to community-based settings, can you share, like, based on kind of what Erica's talked about, what are some of the potential pros and cons or barriers that you see for kind of a practical implementation of this idea in low resource settings? Because that's the whole idea. Community-based settings in the United States are low resource settings. They may not be as low resource as in some low and middle income countries, but they are much lower resource than in most hospital type environments. Can you talk a little bit about that and what are some of the barriers that you would have to overcome in order to do so?
I think the biggest barrier, and really we've been seeing this quite a bit, is just comfort of whoever is running the community-based rehab interventions with robots or with technology, because that's not something necessarily rehab practitioners are trained in, especially when we're talking about high-tech technology, right? How do you get people trained and comfortable to use these kinds of systems? And what happens when things break down? Because that happens with technology. So what is the kind of support or services provided or availability of such services to make sure that, it's very easy to get off technology with one bad experience, and we don't want that to happen. So how do we get people to be comfortable using this technology, and how do we train therapists to know what to do, how to use it? Because I think there are lots of benefits in terms of some of the stuff, Erica, that you were describing in terms of, upgrading, downgrading activities, the variety of types of activities, also some of the social components that can be integrated because of, using dyads. But how do we make it flawless and seamless so that it's not an additional time burden for therapists to be able to use it? I think time is the biggest issue.
Thank you. You have another question from Danelle Jalal, and Danelle asks, what were differences seen when the partition was not between the participants versus when they were able to see each other?
So that is, I think, a future direction. So right now, with kind of the current work study that I was presenting, that one we are keeping the partition in place, but we are planning to remove it when we start to test our adaptive algorithm. So we're going to be testing it without the adaptive and without the partition, and then without the partition and with the adaptive controller. So what do I expect to see? I expect that people are going to talk to each other, because even with the partition in place, people talk to each other. They get really excited and they get really into the game, which is, I think, really gratifying to see that they're really enjoying like playing this game, and they want to talk to people. They kind of want to have that social engagement.
And then there's another question from Toyin. I may have missed it. Were the clinical tests re-administered after at later time points? Wondering if learning translated into improved test scores.
Yeah, so I think that is obviously, if we're looking at motor learning and we're looking at rehab, the goal is that if this were to be applied, we would see some longitudinal growth. I think for this study, we're only looking at a 1 day. And so I think with 1 day of rehab, we really wouldn't expect to see enough of a growth. So we don't do a post-assessment. I know we are, and I'm not as involved with this study, but I do help with some of the controllers. But Dr. Johnson is kind of leading an effort in Philadelphia that's more of a longitudinal rehab study, looking at rehab robotics. And so in like a later phase of that, they might start to use some of these dyadic controllers. And so in that case, we would definitely look at a post-assessment.
We've gotten to our witching hour, which is, well, earlier than our witching hour, which is 11 a.m. If there are not any other pressing questions, I want to just really thank our presenters today for a wonderful presentation. We will have a seminar speaker in February. If you note that the registration link that you registered for today is actually always going to be the same link, and we will try to send out the announcement, but we do have a seminar speaker for the third Wednesday in February, and we look forward to seeing you again there on February 19th at 10 a.m. And we at 10 a.m. on Eastern Standard Time. So since some people don't move their clocks, it's always kind of a little bit of a back and forth. But I thank you again for attending the seminar, and we will see you again. We thank our speakers, and we will sign off. Take care, everyone.